categorically better for everybody. So we try to push that dial and try to make sure that we get as many people as we can within limits to normal ALPs to try and further improve clinical outcomes for people with PBC. That study now has been published in the New England Journal of Medicine just this week. That's the biggest medical journal in the world, for those not familiar with looking at medical literature. So that means it's a landmark study in that sense. You don't get things that are not considered to be practice changing or highly significant into the New England Journal of Medicine. So the full paper is now being published just this week, again sort of highlighting just how much of an important potential breakthrough this is for people with PBC. So that doesn't mean to say it's yet approved by the regulators, but obviously it's an important first step. If you don't get published in high quality journals, usually means the data isn't robust enough. So it's really the first step towards having another potential therapeutic option for people with PBC.
Gotcha.
The second one then was presented, I think it was by Gideon, wasn't it? The Ciladopar data.
Yep.
And that's looking at another drug. Again, the primary, what we call endpoint, what they were looking for in the trial was to see whether the ALP went below 1.67 times the upper limit of normal, and about 60% of patients on Ciladopar went into that category. But reassuringly, about 1 in 4 patients, so 25% of patients, had a normal ALP. And even better news, albeit this is a smaller study and it hasn't yet been fully published yet, was that there was a significant improvement in the amount of itch that people experienced when they were treated with that drug. So actually, this is a drug that can both improve the ALP, gets more people to a normal ALP than any other agent we've had thus far, probably, and also improves your itching. So again, it's only one step towards having another approved medication for use in PBC, but a really, really important one. And I think we're hopefully moving forward to an era where we will have multiple treatment options for people. And again, comes back to that issue of when do we start doing the trials of combination therapy at outset versus waiting for people to fail.
Yeah. Now I'm going to come in here, if I may, because we've had a follow-up question. Now, this kind of follow-up question is one of the reasons why I love the PBC community the way I do. It's informed, it's engaged, it's looking forward, and it's looking bigger picture. And when you have that kind of question from patients, you know that the work's being done. You know that patients are informing themselves, that are following what we do. So and this, frankly, is the type of question that you would expect at an AASLD conference. Okay, are you ready? If elafibranor, and we'll say the Ciladopar, put them both in the same category, is approved to be used as a treatment for URSA non-responders, would that be second line, third line, or in addition to URSA and OCA?
Yeah, and I tell you what, that would be a hard question to answer at the AASLD as well. And the reason it's hard to answer is we just simply don't know. One of the reasons this is a problem is it relates to how the FDA, which is Food and Drug Administration in the US, where most trials now are trialed first in the United States, it requires every single new drug to be compared against a placebo. Whereas I argue that you should be comparing a new drug to the current standard of care, because the previous standard of care has been defined by comparison against placebo. So in terms of moving forward, all we've got is that Ciladopar or elafibranor is better than giving nothing if you don't respond to URSA. We know that if you do nothing, the liver tests are not going to get better, and often they get a little bit worse. What we don't know is whether it's better than obeticholic acid. And we don't know whether using combination therapy of ursodeoxycholic acid, obeticholic acid, elafibranor, and Ciladopar all together at the beginning is going to lead to better outcomes. Logically, using a combination of drugs which all work in slightly different ways will be more likely to lead you to having a normal ALP or an ALP within that response criteria. But the trouble is that as these drugs get more and more costly, then the regulators will always look at what is the cost-effective approach. And for some people, they might respond really nicely to ursodeoxycholic acid and therefore not need additional therapies. And these are the next wave of studies that we urgently need to determine which is the optimal strategy and where these new agents fit in.
Yeah.
What's likely to be the case in the short to medium term, I suspect, wherever you live in the world, is that because these drugs are quite costly at a time of significant financial pressures on health systems worldwide, is that they will probably be introduced sequentially, and they will probably be introduced when people don't respond to the currently licensed medications for PBC, which is urso and obeticholic acid.
Yeah.
That's not to say I agree with that, but that's the landscape that we find ourselves in, and I think that's likely where things will be. I don't know, Robert, if you were party to any other further discussions around that in sort of roundtable discussions during the ASLD, because I wasn't there at the meeting. That's contrary to that, but I think that's generally where things tend to go.
So I didn't get anything separate from that within the roundtable discussions, but what I saw from both the Bezoker trial, which we've not even mentioned yet, and the real world data was that there was a good number of people that responded to a second line therapy. So whether that's fibrates that have been repurposed or OCA, but for those who didn't respond to either of those, if the other one was added, the results were phenomenal. So in my view, with my patient advocate, pink fluffy clouds, ideal world kind of scenario, is that statistically speaking, in masses, it doesn't matter which second line therapy you have. If you don't respond, adding the third makes the difference. It's now, in terms of individuals and personalized care, what becomes the best second line therapy for you. And you're right, we don't have those kind of trials yet to drive that answer. But what a place to be in, to have 4 or 5 options to try and really, again, personalize the medicine, the care to that patient right in front of you at that moment. So amazing.
I think the other encouraging thing to see new agents coming through, which can have dual purpose of both improving ALP with a pretty high rate of normalization of ALP and improvement of specific symptoms vis-a-vis itch. So I think that's another step forward, and a considerable one.
Yep, absolutely. Again, so putting the cynic hat on with my patient advocacy, again, you're hoping that that's enough to make a difference in terms of real quality of life and that kind of thing. So there you go. Okay.
I guess the one other thing I'll just add quickly onto that is that, you use the term personalized medicine, is that I think, although we don't have the data on whether we should use all these therapies together up front, I think Dave Jones is trying to do this the trial on dual therapies in people who are traditionally felt to be at high risk, and patients who've already got established advanced underlying liver disease at the time of diagnosis. I think we will likely see more of a push around using combination therapies early on for those ones that we can identify as being high risk. And I think that's where we'll see the next wave of studies focusing on, is that group of patients we know that if they don't normalize their ALP, they are at extremely high risk of progressing on to having serious liver disease and all the complications.
Yeah, perfect. All right, brilliant. Thank you. Okay, so we have some pre-prepared questions that have come in through the week. So we'll move on to those if we may. So thank you for that. And I think it's really, really important for us as a collective incorporating patients into this conversation to talk about the latest developments at ASLD and these big announcements. So thank you for doing that. Okay, we've had a couple of questions in regard to coenzyme Q10 and also SAMe, which I can never remember what SAMe stands for, to help with fatigue. Any thoughts, any comments?
Yeah, it's an interesting one, isn't it? And the coenzyme 10 in particular, it's in some ways it's surprising there's not more studies in around it, because there are some publications in the medical literature showing that in people with fatigue symptoms generally, not necessarily with PBC, that some patients do experience an improvement in their fatigue. And the reason for that is that coenzyme Q10 is ubiquitous throughout the animal world and in bacteria, in fact, so every single bacteria has coenzyme Q10. So it's a highly conserved chemical. In other words, it's pretty much fundamental to life on Earth. Okay, and the reason for that is that it functions within the mitochondria, which are the little energy cells in the body that you may have heard from previous webinars are really important in PBC, because the antibodies that we measure in the blood are anti-mitochondrial antibodies, and that probably goes some way to explaining why people's energy levels run low and the batteries drain very, very quickly in people with PBC. So there's perhaps particular interest in how these coenzyme Q supplements might help improve fatigue. The challenge has been is that there's only a very small number of actual clinical studies, and one of them showed an improvement in about 2/3 of patients who took it in terms of their fatigue, but that was not a placebo-controlled trial. So it was people who were given it, and they, roughly 2/3 reported an improvement in their symptoms. But when you did it in a proper control trial where people didn't know what they were taking, then actually there was no overall benefit. Now, again, these are relatively small studies, and I think it would be interesting to see some larger studies on that. So at the moment, there's no convincing medical evidence that it will dramatically improve your fatigue, but there might be some indirect evidence from small studies that in some people it might be helpful. And I think crucially, there's no evidence that it's really going to be harmful for you. So, if people come to me and say, "Oh, I want to try this," I'll say, "Well, it's not one of those medications that we would have concerns over with your liver. So it's okay to try it, but it's not something that is prescribable because it's not licensed for that purpose, and there's no convincing evidence. But some individuals will probably derive a benefit from that. And we don't know whether that's placebo effect or true effect and biochemical effect. So it's a really interesting question. And in some ways, it's surprising there haven't been more studies in PBC of this particular compound. But certainly, there's little harm in trying it. And the same goes for the others.
Yeah, no, that's great. So I'm going to ask my own secondary question.
Yeah.
And I'm going to put it in 3 a.m. in the wrong country, so you're jet lagged, so your brain mulls over stuff category. Okay?
Okay.
You got AMA, anti-mitochondrial antibody.
Yep.
You've got mitochondria, which is the energy bit in your cell. Mm-hmm. And you've got fatigue in a condition which has anti-mitochondrial antibody going on. Has anyone done a study to look at if there is a relation between your titer, so how much AMA you have, and how much fatigue you have?
That's a good question. I generally don't know the answer to that. I think if anybody has, if anybody has done it, it's probably Dave.
Right. Okay.
I think it's a really interesting question. I think what's interesting if you look at other autoimmune diseases where we measure autoantibodies in the blood is that they don't always correlate with activity of things either. So that's classically the case in autoimmune hepatitis. You can have a really high titer, you treat people, and some people it comes down and the disease gets worse, and other people it comes down and the disease gets better. So lots of the times the level of the titer, the amount of antibody, titer just literally means the amount of dilution you have to have before you can't measure that antibody anymore. So the higher the titer, the more you have to dilute the blood to not be able to detect it. So that means the more of it you have. So I think, and again, the really tricky part is we don't still understand what the relationship is between the antibody to the mitochondria and what drives the mitochondrial dysfunction. There is indirect evidence of mitochondrial dysfunction in that we know that there's energy depletion in people with PBC compared to so-called healthy controls, in that they do struggle to generate energy or they generate energy in a slightly different way or slightly deficient way compared to people without PBC, at least for some people. But we don't understand exactly how those two things are interlinked and there's going to be intermediary steps. And I think without understanding those intermediary steps, it's going to be very, very hard to really pin down whether the titers is going to be predictive or helpful in terms of whether you're going to get fatigue, how severe it's going to be, and crucially what we can do about it. So it's a really interesting question. I shall have to go away and have a little look about that one because I've not come across any papers myself, but there might be something out there in the literature that someone somewhere probably will have looked at the titers versus fatigue. We certainly don't do that routinely day to day in clinical practice, but it's a really interesting question.
And I wasn't sure if it was one of those too naive, too innocent, too simple correlation.
Not at all.
Right, perfect. I appreciate you coming with me on that particular journey. PBC and here we go. I'm not going to pronounce this right, so feel free to correct me, Andrew. Flucloxacillin. Yep. Okay. So I'm going to mention that particular drug itself also open it up. So the question is, because it says on the leaflet it may cause liver damage.
Yeah.
So what do people with PBC do when they encounter well, firstly, that medicine specifically, and then, you know, the myriad of amazing, I think Ursula Falk for the longest time said it may cause liver damage. So how does a PBC patient deal with that in real world?
Yeah. So the first thing to say about flucloxacillin is that most people who take it don't get any liver injury from it. And the classical liver injury from flucloxacillin is one of duration. So you often have to be on it for several weeks before you get a problem.
Okay.
And the reason why that can be an issue with flucloxacillin is it's often given for quite resistant bone infections. If you've got something called osteomyelitis or chronic cellulitis and you need a 3 or 4 week course, then you nearly always have to take it for more than 2 or 3 weeks before you're going to get any liver injury from it. But it's still, compared to the total number of people who take it, uncommon to develop that. What we know, though, is that actually having an existing liver disease doesn't significantly generally increase your risk of having a drug-induced liver injury. So actually, the fact you have a liver condition doesn't mean to say that you're more likely to suffer a reaction to that drug than anybody else. So at the same time, it never hurts to undertake an abundance of caution. If that's the right antibiotic for the type of infection you have, it is entirely justifiable. And we use flucloxacillin a lot in patients with quite advanced liver disease, with infections of the skin in particular. And we don't have any major concerns over using that in the short to medium term, but we will monitor people's liver function when they're on that medication. So I think if you have an existing liver condition, it is not unreasonable to check your liver tests after having a medication like that. But the absolute risk, that's the absolute number of people who will suffer a liver reaction from those medications, is still small and is not significantly increased by having PBC. So if it's a solid indication for the antibiotic, I wouldn't hesitate to use it.
Okay, perfect. That makes absolute sense. Thank you. Next question. I suffer from, I'm glad that you mentioned bone pain previously. I suffer from bad bone pain. Any advice?
Right. So bad bone pain. The first thing I would say is if you have PBC and you have bone pain, it's really important that you probably have your vitamin D levels checked or you've had a bone scan, because one of the commonest reasons you can get bone pain is from bony microfractures. Don't be alarmed. It's not like a long bone fracture where you crack your arm and it goes into plaster. But if you have a low bone mineral density, which is more common in people with liver disease generally, that's if you've got advanced liver disease, cirrhosis, or if you have cholestatic liver disease, of which PBC is one of those cholestatic disorders, then you are less likely, or you're more likely rather, to have osteopenia, thin bones, or osteoporosis, holes in your bones. And that makes you prone to getting microfractures, and that can lead to bone pain. That's not to say that every bone pain is related to osteoporosis, osteopenia, or microfractures, but I would say in the context of somebody with PBC, really important that you've had a bone scan if you haven't already had that done. If you can, some areas will check vitamin D levels, some areas won't. But if there's any doubt, we normally just give people some vitamin D. What's interesting is that NICE, which is the regulatory body in the UK, recommends vitamin D for everybody in the UK in the winter months. Everybody, irrespective if you've got liver disease or PBC. And that's because, as Robert lives in Scotland, I live in Wales, we never see the sun, even in the summer months, and very, very rarely in the winter. So, you know, if you're having bone pain there and vitamin D levels are not available, then some vitamin D supplementation is not a bad idea, particularly through the winter months. So that's what I would say, is to get those things checked out, because it's really important that you've not got a related problem to your PBC whereby your bones have got a bit thin, because we know treating those things early on will tend to lead to improved bone health, reduced risk of actual long bone fractures and hip fractures and spine fractures, etc. And in people who've got low-level bony pain, it can lead to significant improvements in those.
Wonderful. Supplementary question again, if I may.
Yeah.
Would those tiny bone splints and that tiny bone damage cause havoc with your ALP?
Yes, they can. So ALP is not just produced by the liver, as you've rightly identified. Generally speaking, so what's interesting, in the general population, so people without PBC, take everybody in the whole population, the commonest cause of a raised alkaline phosphatase in the general population is vitamin D deficiency.
Okay.
Okay.
Right. Right. Okay.
So
Right.
yes, if you are vitamin D deficient, your ALP can be higher. And actually, it's one of the things I don't think it's ever probably been properly explored in terms of, you talk about non-responders. Could you have, the assumption is if you've got an AMA that's positive, you've got PBC, and you do have PBC, but actually, should we be checking the vitamin D levels in everybody who's a non-responder? It's an interesting question. I don't think it's ever been formally studied, but certainly vitamin D deficiency is relatively common in the general population. It's a common cause for the ALP to be elevated, because what happens is if you're lacking vitamin D, you're turning over new bone more, because the bone you're forming is a little bit less stable. So you're turning over new bone, and so that enzyme is working harder. You're producing more enzyme to lay down new bone. And so it will go up. And that's relevant to, I think, another question that's coming through a bit later on as well.
Fabulous. I love these sessions. Thank you so much. Right. Next question, if I may. Right, this is a really important question. So I'm going to basically, we've got somebody who's newly diagnosed with PBC.
Yeah.
They have bipolar disorder and on 5 meds to keep them stable. Have been, amazing mental health over the last period, and they're obviously concerned in terms of PBC disease progression, or medication for PBC having an impact on that. Do we have any data or any kind of real world evidence or anything we can share to help here?
So no, I think it's a really important question, and I think whenever you're looking at what's called polypharmacy, lots of different medications, they always have to look at are there drug-drug interactions, and for some medications, particularly newer drugs, that's usually more of a concern, because we've had drugs like ursodeoxycholic acid around for a long, long time. We know that it doesn't really affect the absorption of other drugs, so we don't have major concerns about drug-drug interactions.
Yeah.
So it shouldn't lead to altered levels of different medications that would be used for conditions such as bipolar disorder. Some medications used for bipolar disorder, though, are metabolized by the liver. Well, most of them will have some degree of liver metabolism. And in people who've got very advanced liver disease, I'm not saying that's the case for this person who's asked this question, but for some people, if their liver disease progresses and they have very advanced liver disease, I'm talking really about people who've started to develop jaundice and liver failure, then in some people, the metabolism of those drugs might be reduced, and that could lead to toxicity from the medication. But for the vast, vast majority of people with PBC, it shouldn't have a significant impact, and it shouldn't be a significant concern. But it's always important to report that to whoever's looking after your liver disease, your primary care physician, and whoever's supporting you from a mental health perspective, just to be 100% certain, because they will know the specific agents that you're taking. But in general, urso is perfectly safe to take with the vast majority of medications. The only concern comes if you've developed more progressive liver disease, in which case the general metabolism of all drugs, including drugs for your mental health, can be diminished, can be reduced, and so you can develop toxic side effects when you've previously been okay on those medications. So in some circumstances, there might require to be dose reductions of certain medications.
Okay, perfect. That's helpful. Thank you very much. Somebody else now concerned about cholestyramine. So I'm going to ask you a general question about cholestyramine, because some of the people watching this might not know anything about it. They might be here for the first time. So questions to do with the timing of cholestyramine, the dosing of cholestyramine, and the efficacy of cholestyramine. So what can you tell me, please?
So cholestyramine is a drug that we use to treat itching in people with PBC. Effectively, it binds bile salts in the gut. Okay, so bile salts are secreted by your liver into the intestine, and then they're absorbed in a part of the intestine. And in some people, they don't absorb it that well. But also, if you're producing too many bile acids, then potentially trying to bind them in the gut might minimize them out, and then getting reabsorbed in the system that can get in, trigger itching in the skin. So that's the rationale for using cholestyramine. According to the product literature, cholestyramine is a 3 times a day medication, but actually in practical purposes, it's not the nicest thing to take, as I'm sure the person who's raised this question will testify. But actually, twice a day administration seems to work as well as once a day. Now, This is a drug that effectively just sits in your gut, okay? It doesn't get absorbed, okay? It literally just absorbs bile salts in the intestine. So because it doesn't get systemically absorbed, even though the product literature says you should take it 3 times a day, we use it typically in liver disease twice a day. And the problem can come because it binds stuff. It also binds stuff other than the bile salts. So as I think the question alludes to, sometimes it's difficult to balance taking the medication with all the other drugs you've got. So you might be taking medication that says take this on an empty stomach, this one 1 hour after food, and those things can make it difficult to time it. So the product insert will generally say don't take it, more than one, in one go. I think the problem is that there's not much evidence that taking 2 sachets in one go is going to do you any more benefit than one, because you're going to probably have maximized on the dose. The reason for recommending it 3 times a day is that sometimes you need to take it more often than that. So I don't tend to recommend people taking a double dose, because I don't think there's much clear evidence it'll deliver a better benefit for you, and it certainly won't deliver a longer benefit for you. What I would say is that if, because of other medications, you're finding it hard to get the second dose in and you're still having problems with itching, cholestyramine is really at the bottom of our itching ladder, okay? Our itch treatment ladder. So there are other treatment options further up the ladder with greater effectiveness. So I would say if you've got lots of other medications that's making taking twice daily cholestyramine difficult, speak to your liver doctor or gastroenterologist, whoever's managing your PBC, and see if they can use something alternatively, because I think there are other treatments that are often more effective, and logistically it's going to be difficult for you to take that more than once a day.
Okay, thank you. I remember back in the day there was a lot of talk, so going from 1 sachet, and when people went to 2, they took 1 before, 1 after breakfast.
Yeah.
And that seemed to improve things. Is that still a thinking? Is that still a...
Again, from a pharmacokinetics, so that's how drugs function point of view, I think the dose is normally set at what the optimal effectiveness will be. And so, the trouble is lots of these things have been done in really small numbers of people. And sometimes you'll just get a natural variation in how people will respond and how they will absorb it. And so it's not something that is commonly practiced to sort of split one morning, one before lunch, one after lunch. Again, what's the absorption going to be after you've just had a meal as well? The effectiveness of it when you've already got when you've got food in your stomach. So I think in general, because it's not a wonder drug for itching, it can help some people. I would generally say if you can't take it as prescribed, look to see if there's another option for you that's going to fit in better with the existing conditions that you would need to take medications for.
Brilliant. Ideal. Thank you so much. Okay. I have a collection of autoimmune and other medical conditions. So first thing I'm going to say, stop. Okay. We know that 42% of people with PBC will have at least one autoimmune condition. But if you're getting to 2 or 3, it's a bit greedy. So just stop there if you can. But on a more serious note, I have medications to take, steroid tablets, prednisolone or prednisone if you're in the US. The other condition is polymyalgia rheumatica. Is this a problem with respect to my PBC? I mean, is it linked? Is it caused? Can it be a challenge to the PBC, etc.?
So in terms of, is it linked? Yes. I mean, as you've already alluded to, about 40% of people will have one other autoimmune condition. 10% will have 3 or more. So autoimmunity is basically a genetic predisposition, and then it's often just in the laps of the gods about which organ it'll tend to affect in which individual. So from that point of view, yes, there is a link. Is taking long-term steroids damaging for your PBC? Well, there's no evidence that it's going to make your PBC any worse. But where it can be problematic, coming back to bone health, is that we know long-term steroids are bad for bone health. And so it's really, really important if you have then 2 reasons to potentially have poorer bone health in the future. That's your PBC in terms of not absorbing the calcium properly. And secondly, losing more calcium from your bones because of the steroids. Then it's really important that you've had a proper assessment of your bone density with a DEXA scan. So that's really, really important. I would also, it's most patients who are, or people who are taking long-term steroids at significant doses, so above 7.5 milligrams a day, would be hopefully on some calcium vitamin D to try and offset some of that bone loss. And some people will need stronger drugs again to counteract that, depending on what the bone scan shows. So yes, it won't worsen your PBC. Yes, it is linked. But the really important thing is that you've had a proper bone health assessment. And really, at the very least, if you're not on vitamin D supplements with calcium in terms of tablets, get more calcium into your diet with milk, cheese, yogurts, dairy products, those sorts of things, whilst you get professional advice about the optimal treatment to offset that bone loss for you.
Nice. All right, perfect. That's helpful. Thank you. A couple of hellos. One's coming in from the US. One's coming in from Ireland. So we have somebody saying, I've been told I have a polyp on my gallbladder and referred for a surgical consult. Is this a side effect of having AIH stroke PBC? And is there any risk to me on a removal of the gallbladder with my condition?
Okay, good question. So PBC is associated with gallstone development. And while they've said that there's a polyp in your gallbladder, it can often be very hard on scans to differentiate between a polyp and a gallstone. So if it doesn't move, polyps and gallstones can look almost identical. And it's not uncommon you'll take out a gallbladder for a polyp and it'll turn out to be a gallstone, or vice versa. So yes, there can be an association between having stones in your gallbladder and having PBC. In terms of gallbladder polyps, they are reasonably, if it is a true polyp, they are not that uncommon in the general population, and we often take out the gallbladder if the polyps are large, because gallbladder polyps can develop into something more sinister. So if they're of a certain size, it's often quite reasonable to take the gallbladder out. The important thing is that you alert your surgical team that you do have a liver condition. And then in terms of, is that a risk for you? It's not a risk in terms, it's not going to make your PBC any worse. But actually where it becomes important is that if you have advanced liver disease, and I'm talking about cirrhosis there, then a proper risk assessment needs to be undertaken about the relative consequences of surgery. Because in people with advanced liver disease and cirrhosis, a small proportion can deteriorate after any type of surgery. Although gallbladder surgery is relatively low risk, there is a high risk of developing liver failure if you've got established cirrhosis before you undergo any kind of surgery. So that just needs to be factored into if you've got advanced liver disease. But if you don't, and you have PBC and that's stable in your medication, or even if your ALP is high but you haven't got cirrhosis, that it should be no higher risk than anybody else.
Yeah. Okay. Perfect. Thank you. So again, supplemental question on the gallbladder, if I may.
Yes.
So, having met literally thousands of PBC patients, and one of the things that comes up at meetings or conferences is, have you had your gallbladder removed? And it feels, and so I've no data, just a feel that quite a lot of PBC patients have. And there's a kind of wondering within the patient community in terms of, is that kind of problems with the gallbladder that are related to PBC not being picked up because of PBC? Has it affected the PBC? Does the PBC affect the gallbladder? And therefore it's had to be, it just feels statistically a lot.
Yeah.
And there's nothing we can change about past behaviors, but I'm just wondering if somebody has some knowledge about this, it might help improve things in the future.
So the thing is with gallstones, they're very common in the general population. So that makes it really hard to then identify whether they're more common in a relatively uncommon condition like PBC.
Yeah.
Other risk factors for developing gallstones in the general population are being female and over the age of 40, which is what most people who have PBC are. So not exclusively, but we know that most people with PBC are over the age of 40 and most are female. So actually the risk factors for both things are, or they share common risk factors.
Yeah.
So it's really, really hard to tease out. We do know that people with PBC do seem to be at an increased risk of gallstones compared to the general population, though. So if there is an association, doesn't prove causation. That's a common phrase of mine. So association does not prove causation, but if there is an association, some of that might be driven by shared risk factors, vis-a-vis being female and over the age of 40. But I think from what we do understand, I think at least from the data is that I think people with PBC are more prone to forming stones, and so that might make you more likely to be symptomatic and therefore need to have your gallbladder taken out. We don't have any evidence that having your gallbladder taken out modifies the disease in any way, shape, or form, and biologically that doesn't really make any sense either. So if you need to take it out, don't be alarmed at that. If it's recommended and people know that you've got a liver condition and they've risk assessed you to make sure you're not at high risk of surgical complications, then you should have the operation as per anybody else.
Okay, perfect. Thank you. Okay, we have somebody who's 74 years old and was diagnosed in 2008.
Okay.
Been on URSO and responded well. Alk Phos down to 120 from 220.
Yep.
She sits between 50 and 50. However, in the last year, they've noticed Alk Phos just starting to creep up. And so they're asking the question. GP seems to think it might be age-related. And the patient's just asking if you had any thoughts on that, or, is that a thing as you get older that your Alk Phos goes up, etc., etc.?
Yeah. Do you know what's really interesting about doing these sessions, Robert, is how some of them, the questions don't come up in any sort of given theme, and all of a sudden in one of them you'll get 3 or 4 things which all relate to a similar theme. And this one relates to a theme we've already talked about today, and that's what else causes your ALP to go up. So the first thing to say is that ALP can fluctuate, okay? It doesn't fluctuate wildly in PBC in the same way as the ALT level fluctuates in autoimmune hepatitis, but it can fluctuate. It's just not uncommon for it to go up by 10-15% and be a sort of, a rough fluctuation around that. What causes that? Well, there are hormonal factors can bring about changes in your ALP level, less likely at the age of 74, but certainly bone factors might be at play here. So again, bone health, I think, would be a really important thing to focus on. And I think particularly if you've got more significant underlying chronic liver disease and an understanding of your bone health, maybe a check of the vitamin D level, or if I know vitamin D levels aren't checked in every part of the world, and in some regions in the UK, some labs will do it, some won't. Some will say, if you're suspecting it, just give vitamin D and see what happens. So if you can't do a vitamin D level, then try some vitamin D to see if that has an impact on it. Bringing it back to the PBC, though, you're still in a lowish risk category because you would still be well within that response criteria. And I think if you don't have significant underlying chronic liver disease, then I would be super chilled if you're 74 with a relatively normal FibroScan and an ALP that's 140 odd, then you're in a low risk category for liver disease progression.
Brian, thank you very much. So it's almost as if by magic, you talked about hormonal influences. So the next question is actually, so they're asking, are fluctuations, could they be linked to menstruation, to menstrual flow itself, or to giving birth? So somebody spoke about LFT spiking after giving birth, but then back to normal again. So what do you know?
So I'll address the giving birth bit first because it's pretty straightforward. We've talked already today, this is that theme again, your ALP is most commonly produced by your liver or your bones, but it can also be produced, or it is also produced by the placenta. So in the 3rd trimester, so that's the last third of pregnancy, the ALP starts to go up in virtually everybody. Okay, so it's very, very common to have an elevated ALP enzyme later in pregnancy, and that will last for several weeks after pregnancy. I have certainly seen people during pregnancy as well develop cholestasis of pregnancy, which is a non-related condition to PBC, but causes cholestasis and can cause a rise in the ALP, and that can persist for several weeks after childbirth. So absolutely ALP, you'd expect it to go up towards the end of pregnancy and to stay up for a wee while after pregnancy, but then once that placental effect has gone away, once the placenta has been delivered, then it should go back to its baseline. So in relation to that one, absolutely yes. Can it go up with menstruation? Also yes. That's an interesting one, isn't it?
Yeah.
And so it's probably a progesterone effect, but certainly it's well documented that ALP can fluctuate during the menstrual cycle. certainly in the proliferative phase. That's where the endometrium is proliferating, getting ready for the next sort of shedding cycle. So yes, it can absolutely go up. In terms of menstrual flow, I think that's less clear, at least in my own mind, about what the relationship is. Now, it might well be that those who have heavy menstrual flow have higher hormone levels, which might mean the fluctuation is higher. So I guess that is plausible.
Yeah. Okay.
But I don't think that's been as well established or as well studied. But it is very clear that ALP does fluctuate during the menstrual cycle.
I'm going to have to sit with that for a minute. That's brand new information to me. So
it's wild, isn't it?
It is, absolutely. So, the fluctuation comes up quite a lot and it concerns patients. And I guess that's just one more potential reason to highlight that actually if your alpha is going up and down and doing that thing. So thank you. That's, on you go.
No, I wasn't going to say anything more about that. Really, there's just a very, it's a really, really good question. It's not one we've had here before, but yeah. And again, it's about. I think the levels of fluctuation probably would be relatively narrow physiologically.
Yep.
What that does if you have another condition that affects your bile ducts is the bit that's not well studied. So we don't really know what degree of fluctuations we might witness.
Yeah.
But it would certainly be very interesting to hear more about that from others if that's been something that other people have seen themselves when they've gone for their blood tests.
3.5 years in, still getting brand new questions. It's brilliant. Yep. So, all right, thank you. Okay, next one, if I may. Recently diagnosed, just started or so, and for the first time ever experiencing pain in the liver. So I'll ask you about pain in the liver itself. And then almost like a burning sensation. Never had it before. Is this normal? Will it go away in time or with time?
So I think the first thing to say is that if you're experiencing a new symptom when you're taking a new medication, you have to be suspicious that the medication might be responsible for that. Okay, so again, association doesn't prove causation, but actually if it's happened and you've never had it before, then it's fairly reasonable to say there's a high likelihood that the medication might be triggering that. Should urso cause liver pain? Well, it shouldn't. And the reason for that is that the liver itself has no nerve endings other than the capsule around it. And urso doesn't inflame your liver. It's not toxic to your liver in that sense. So we wouldn't expect it to cause liver pain. But of course, where the liver sits is not the only organ in that part of the body. And so pains in parts of the gut can be experienced on the right-hand side. And it's quite common when you see people with IBS, for example, who will complain of pain over the liver, and it can often be quite localized. And actually, it's nothing to do with the liver at all. It's actually due to the gut. So this might be a gut effect from the urso. Okay. Now, sometimes there are ways around that. Some of these side effects people get when they take new medications, and gut effects are the commonest side effects of urso. Diarrhea being the commonest one, but some people can get some generalized discomfort. Sometimes reducing the dose can help. Sometimes splitting the dose if you're taking. Some people take it all in one go and know it's licensed to be taken 3 times a day. But sometimes reducing the amount that's being delivered to your gut at any one time point might help with that. And if that doesn't make a difference, then sometimes you need to consider having a short holiday off it just to see if it goes away. Not long, a couple of weeks, because if it is directly related to that, then the symptom will get better very, very quickly. And then if you need the urso and a re-challenge then causes the problem to come back, then that's an indication for consideration of obeticholic acid. It's very clear the license is non-response or intolerance of urso. So intolerance to urso is actually relatively small, and in many patients you can get around it by a slight reduction in dose or a short holiday away from it and then reintroducing at a lower dose and building back up. And for most people that's perfectly safe to do. And that's what I would normally do in my practice.
Okay. And another thing I've heard often is changing brands.
Yeah, absolutely. So there's the other options you can try liquid preparations and try and do granules, for example, because absolutely some of the things can be related to not the urso itself, but some of the other constituent to assist absorption of the drug. Yeah.
Perfect. All right. Thank you very much. Again, you talked about a different protocol into second-line therapy, which is our next question. So I know that this will vary from country to country, but the question is, what is the protocol for starting second-line therapy?
Oh, okay, right.
Nice, easy one.
Yeah, well, I think in some ways it is easy. It's complicated by regulatory bodies and what's been approved and made available, isn't it? So the simple thing is, the basic principle is that everybody with PBC, with an elevated ALP, should be offered ursodeoxycholic acid, and they should be monitored for their response. You can argue whether that's 6 months or 12 months. Currently, it's 12 months officially, but at least there should be a formal assessment of response at the very least at 12 months after taking that medication. And if you don't meet response criteria, you should be offered second-line therapy. And for the majority of people, that should be obeticholic acid because that's the licensed drug, but it's not available everywhere. I think we found at that meeting in Edinburgh, didn't we, Robert, that in some parts of Europe, surprisingly, it's not available at all. And so that would be with what is available locally, wherever you happen to live. So obeticholic acid is the licensed drug. Fenofibrate or bezafibrate are off-label uses, so that should be discussed with you, as a patient, that these are not. There are trials to show that it's effective and is generally safe, but it is not a licensed medication, so you should always be aware of that. And so I think it's the local availability and what the regulators have approved for use for PBC will dictate what is available for you. But actually, the preference should be, as long as itching is controlled, that obeticholic acid should be the preferred second-line option. But some people do have significant itch problems, and that needs controlling before you go on to obeticholic acid. And so sometimes locally, even though we have good access to obeticholic acid in the UK, there shouldn't be a restriction on you having availability of the drug. Sometimes I do use bezafibrate to, both improve the liver test and get the itching under control. Sometimes there's a bridge to using obeticholic acid, but it's really important that the itching is controlled. The waters will get a little bit more muddied still if the other drugs become licensed in terms of where they'll fit in. But I think that the overarching principle should be, you have PBC and a raised ALP, you should be on ursodeoxycholic acid, absolutely yes, at the right dose, which is 13 to 15 milligrams per kilogram. You should be assessed at a year, and if you're not, you should be offered whatever your locally approved second-line agent is, and then reassessed from there. And if you still don't respond, you should be considered either for anything else that is currently available or clinical trials if they are also available to you locally. Those are the principles, I would say, in terms of pathway.
Yeah. Okay. Thank you. Now, I do know the phrase like ALK-Phos 101. So this is a kind of, I don't, what comes after 101? Is it 102 or 202 or I have no idea. But we can consider that over I've had to talk to them one evening. But coming back to, this seems to be an ALK-Phos specialized edition of our Q&A. So this is to do now with HRT. Now, again, this is a question that's come up quite often, actually, in terms of, is HRT contraindicated? Does it affect ALK-Phos or anything else that goes? Now, the patient specifically is on the patch, just so that you know. But the basic question is, any risk, any contraindications in terms of HRT and their PBC, please?
Yeah, again, I think if you have a really good indication for being on HRT, then that should not be prevented by having PBC. But again, you are ingesting sex hormones, estrogen and progesterone in particular, can have impacts on ALP, and so that needs to be factored into. So I think what I would say is that it should not be avoided if it's indicated, but if there is a spike in the ALP afterwards, then that might be a causative reason. It doesn't necessarily mean to say that your liver disease is getting worse, because it's not necessarily affecting your liver. It could be having bone effects as well. So I would not discourage or dissuade somebody from taking HRT off that basis, but I think it's not unreasonable to just have a liver function test check. No fixed interval, but usually probably 4 to 6 weeks after commencing. And if it hasn't budged, then it's probably not going to, and you just crack on. If it has gone up, then it's a conversation between the primary care physician and whoever's instituted the HRT and whoever's looking after your liver condition to determine whether that should be reduced down, different dose, different brand, whatever, and then re-review from there.
Okay, perfect. Thank you very much. Now, again, ALK-Phos second-line therapies, and this is where you and I have been pushing hard, but we're not across the line in terms of a change of policy yet. So, partial responder, ALK-Phos was 200.
Yeah.
It's now 170, 180 after 2 years. Was on Biza and then Pheno, but muscle ached, UTI, and so was discontinued.
Yeah.
Not over the threshold in terms of Ocaliva.
Yeah.
So the hepatologist is suggesting a trial. So I think the general question is, what do we know? What can I do? What can I ask?
So I think one of the real challenges in this regulation space around new medications is that what the regulatory bodies want to know is that is a new therapy effective, and what defines effectiveness? So within PBC, we use a fall in ALP as what we call a surrogate for long-term improvements, because we know it took us a long time, Robert, didn't it, with URSO? It took about 30 years after URSO was introduced for PBC to actually demonstrate that it led to a reduction in liver transplantation rates. Yep. When I first came through as a baby doctor, I was told that it had no meaningful impact on the natural history of PBC, but it made the ALP better. Then we had 20, 30 years worth of collaborative data which showed that actually people taking URSO and had a reduction in ALP were less likely to progress to liver transplantation. But that took 25 to 30 years. So the part of the problem is that the regulators want data showing what we call hard endpoint improvements. So that's a reduction in deaths, a reduction in liver transplantation, cirrhosis. But if you have PBC diagnosed today, that might be 30, 40 years before that happens for you. So we can't wait 30, 40 years to try and work out whether that's going to be appropriate for people. So we use surrogates like ALP reduction to bring that about. What that means in practice, coming back, that's a long-winded way of saying that in practice, it's very difficult to recommend giving everybody with an ALP under 200 other second-line therapies, because some people won't come into any harm, and we know that if you're in that response criteria, so if your ALP is less than around 200, 215, your risk of developing progressive liver disease is going to be a lot less than if it's above that threshold. With me so far?
Yep, I am.
So what I think that speaks to then, what becomes really important is, do you have significant underlying chronic liver disease? Because if you didn't have cirrhosis at the time of diagnosis, but your ALP is below 200 and you've still developed cirrhosis with that, to me, that makes you more likely to be in that category of people who are responders, for want of better phrase, but still have developed progressive liver disease. And we've seen this with URSO, we've seen it with the obeticholic acid. I've seen people have normal ALP on obeticholic acid and still progress their fibrosis. So I think if somebody has advanced liver disease, I think at the moment the current criteria would say no, but actually if you could make a case to the local ODN in England, which is how obeticholic acid is delivered. In Wales, we have a virtual panel. You can make an appeal, and it says this is not standard criteria, but look, this person has now developed cirrhosis. We don't want that to progress on. And we have, on at least one occasion in Wales, looked at a situation like that where somebody's ALP was below the 210 for our labs, but actually they've developed scar tissue over the last 4 or 5 years that actually suggests that there's a benefit in trying to get that ALP down to normal as close as possible. And so I think if there is significant underlying liver disease, I think that should make it, that should lead to a change in approach on an individual case-by-case basis. And at least there can be an appeal then to the ODN where there's that central control over to make sure that the drug is used appropriately.
Yeah. So I'm not going to share my thoughts because they're not entirely, they're close, but they may not be helpful at this juncture. But I guess what might be helpful to share is that back in the day with obeticholic acid, there was a clinical trial criteria that made you eligible or not.
Yes.
And that eligibility was that year of non-response to URSO, and then having that ALK phos of over 200 as a threshold. Because for a clinical trial, it made sense that if it was high enough, you could show improvement. And somehow, because that was the circumstances under which the science happened, that suddenly became the threshold. And I think as we go on more and more and more, there seem to be these patients who have under 200 whose disease is progressing. And we as a community need to address that. But again, I just wanted to give some of the background as to why that 200 is a magic figure and where it came from, if that's helpful.
Yeah, no, that's a really good point. So that 200, which is roughly 200, is the threshold of that 1.67 times upper limit of normal I mentioned at the beginning. And that's now being used in all the other subsequent trials now, isn't it? It's the threshold that was used in the elafibranor trial. It's the threshold that's used in the ciladelpar trial. So it's become that sort of de facto standard that people have to meet. But as you and I know, we're pushing to say that actually, if not for everybody, certainly for selected groups of people, it shouldn't be, some people will still develop progressive liver disease even below that threshold.
Yeah. Okay, perfect. Thank you. I'm aware of time, so we'll just go into a very, very quick fire round, if I may.
Yep.
Inflammation of the, I'm going to say mucosal.
Mm-hmm.
Is it connected to PBC/autoimmune conditions?
Potentially. I mean, I think some people can get Sika syndromes can lead to pain and discomfort in the mouth and the mucosal membranes in the mouth and the eye, for example. So if it's related to that, dry eyes, dry mouth, then absolutely yes. Some people are just more prone to sort of cold sores, ulcers, and things like that. But certainly, always think anybody describes mouth symptoms to me when they have PBC, the first thought is, do they have associated Sika syndrome, which is where you get autoimmune destruction of the salivary glands and the tear ducts, which means you don't produce enough of that, and so you can get dryness and then secondary blistering or cracking and soreness. So always think about those things, and if those are significant problems, then certainly seek formal medical attention with either your GP or your hospital specialist about that to see if there's any therapies available.
Okay, perfect. Thank you. Semaglutides?
Okay, yeah.
Can Dr. Yeoman please discuss whether there are any reasons if a PBC patient on URSO with stable, so the question says stable liver function test, but that's a different question. But with stable liver tests, any reason why you should not be prescribed semaglutides?
So the key question is semaglutide indicated for you? The commonest reason at the moment for that is that you have type 2 diabetes with poor blood sugar control. So semaglutide is, most people have heard of it either Ozempic, which is this weight loss injection that people take once a week. Yeah. Okay. So the formal indication is for type 2 diabetes, but it has been licensed by NICE as a potential option as part of a weight management service to facilitate people to lose weight. So it tends to lead to about a 7 to 10% body weight reduction. So there's no contraindication. There's no reason that they will affect your PBC, and certainly if you have problems with weight gain, that can lead to fatty liver disease, and taking some of that fat out of your liver might even help your liver in the longer run. So there's no harm with taking that if it's clinically indicated and prescribed by your doctor. I would not have a concern about that. And I've got at least one person I look after with PBC who's, well, more than one, who was also on semaglutide because of diabetes.
Got you with you. Okay. I shan't name the hospital. If somebody says they're going to a UK hospital next week for a second opinion regarding transplant. So the question there is, what can I expect?
Yeah.
But I'm going to add on, what questions can I ask as a patient to help the process?
Yeah, good. So I'm sorry you're having to go through that. I mean, that's a tough process to go through. There's no doubt about that. And I think certainly for second opinions as well, that's you've been, I'm assuming you've then been through the process once. So so the transplant process is quite formalized actually, and it's there'll be tweaks of variation, but the basic principles should be the same in all the transplant centers in the UK. What in essence the transplant process is there to do is to answer two questions. One, is liver transplant indicated for you? In other words, is the risk of doing a transplant outweighed by the benefit to that particular person? So is the disease severe enough? How much likely they are to come to harm without transplant versus what the harms of transplant are? That's the first question they have to ask.
Yeah.
The second question they then have to ask is this person physically robust enough to tolerate transplantation and the aftercare with the anti-rejection medications? Because transplantation is an enormous undertaking surgically. It's an extremely long operation, can have significant strain on heart, kidneys, lungs, and other organs, to say the least. Post-operative recovery, and then will the kidneys tolerate all the anti-rejection drugs and things like that? So that's the secondary question. So what the process involved is a very intensive process. It's quite stressful. You tend to meet lots of people from the hepatology doctors, that's the medical liver doctors, liver surgeons, often meet an anaesthetist, so somebody who would do an anesthetic on somebody. There's often lots of specific tests around the robustness of other organs like the heart and the lungs, like echo scans and lung scans, etc. You might meet you'll meet the transplant coordinators. And then usually at the end of that process, which usually happens in a hospital stay of usually 2 to 3 days, then usually there's a multidisciplinary meeting at the end of that period, and then the outcome of the answer to those two questions is relayed to the person in terms of, and then a discussion is had around that. And some people are then listed for liver transplant, and then they go on the waiting list with all the sort of uncertainties that comes around with that, in terms of then waiting for an organ to become available. Or in some circumstances, sometimes sadly people are not, sometimes they're not deemed severe enough at this point in time for liver transplantation. Or they might be deemed severe enough, but actually that their heart and lungs are not strong enough to help their body through that process. So, I really wish this person well. It is a stressful process to go through. So, thoughts with you on that one as you go through that. But what I know is all the transplant units in the UK work to pretty set criteria around this, and they undertake a lot of due diligence at every step of the process. So you'll be in good hands.
Yeah, okay. And this is something we probably should have said earlier, but in terms of anybody who is engaged in any of these questions, or if you have concerns about where you are and we can support you in that, then please do give us a call and talk to one of the trained and professional staff here at the foundation, and let's see if we can help you in your journey. Okay, thank you very much. I have one last question, if I may, and it's just because, again, there's an emotional aspect to this, and so here's the thing. Recently diagnosed with PBC, and I've piled on the weight in the last year, and they're talking about 2 to 3 stone. Regularly exercise, regularly diet, but they're only shifting about 6 pounds. They've always been able to lose weight in the past. Is this to do with PBC? Is it to do with URSO? And they're just saying anything I can do because it's really getting me down.
Yeah, we see this quite a lot, don't we, Robert? And I think we've heard from people in the past around this. And I think, there's nothing specific about PBC and what it does to your liver that should make you gain weight. But we know the impact of having any chronic condition, and particularly the fatigue, and sometimes the itching, if that's keeping you awake at night, you're going to be even more tired. The ability to undertake physical exercise, or the ability to even just eat healthily, everything just becomes difficult. And so we see this time and again with lots of chronic conditions, including PBC. So sometimes there's just an associated loss of vigor. People feel just less well, they're less robust, they're less physically functional, and that can certainly contribute to weight gain, as can getting older. As every sort of year after about 40, your metabolic rate slows down, you find it harder to lose weight when you've gained it. So there are often indirect reasons why PBC, or people with PBC, can gain significant weight, and it's way harder to lose weight than it is to gain it in the first place. So I think that there isn't anything specific I can recommend that, in relation to the PBC. I think what we can say is that certainly speak to your GP about what other services might be available to help. Lots of areas have weight management services that are run by specialist dietitians, and they'll often do a needs assessment, and they look at aspects such as physical therapy. They look at specific dietary advice, and also within those services, within the next 6 to 12 months, there may be the option of using, for selected individuals, these drugs like semaglutide as a weight loss adjunct. So, being part of one of these weight management services is really important to get the right information, the right advice to help you lose that weight that you've gained, and then to monitor you, and then to be able to offer you new therapies and new interventions as they become available. So that's what I would strongly push for.
Okay, perfect. That's really helpful. Thank you. Dr. Andrew Yeoman, thank you so much. It's been a great session today. I really appreciate your time, your expertise. Some new questions we've never been asked before. Some old favourites that come up periodically, and so it's great to get your thinking on those. And some brand new topics in terms of the new science that was announced just this week. So good session. Thank you so much for joining us. Good to see you.
No, pleasure. Good to see you as always.